I'm not a medical expert, although my father is a surgeon, but I will try to answer all your questions. Otherwise, I will take them back with me and ask experts to help me. So maybe I can use this one, yes. So I will present the CROWDHealth project. This is also an H2020 project, and it's about the development of a platform to incorporate, and as we have heard, we have data from many different sources. I will come back to this, and to use all these data, and if possible big data, to inform policymakers and public policy in healthcare. We are at the end of the first year of the project, and this is what I will present. It's formed by many partners, almost 20 partners now, several large companies and small companies, a lot of universities. The recent partner also is Taipei Medical University, is coming in to bring also a large amount of data, patient data that they can collect in their whole country. So this is interesting. In a very short snapshot, what it is about. As I said, we have to acquire information. This information is completely heterogeneous. It is from different data sources, and it comes from collective knowledge. We put many aspects together. And what I will define later as well, what we call social holistic health record. We have heard about health, patient health record, and I will present the social holistic health record. And CROWDHealth is working around all those different categories of activities. The first one is, of course, big data management. We capture a big amount of data. We need a secure infrastructure, an infrastructure that can capture, store, manage all this data. We also need to take care about the data governance so that we have reliable information. We heard before, Katarina, I think she mentioned that we need to pre-treat the data. We need to clean it so that we have reliable information. Then, to understand all this information, we need, of course, data visualization and data analytics. So we will provide also these kind of tools. And it's also about the creation of policies based on evidence. So we will have in the background data coming from chronic diseases, health centers, social networks, living labs, public environments. All those are different sources of data, heterogeneous data. And those feed in as well into the project. And our ultimate goal is to make policy evaluations and simulations. And this also feeds back into the loop so that we can use those policies and simulations and data from the impact of policies to, again, produce new policies. Just that we are on the same pages. It's, of course, about electronic health records. We heard this word these days many times. Some call them personal health records, and we talk about holistic health records. And what we understand as holistic is that it's all kind of information that is health related. So it contains additional data that can be contextual, that can be on the weather, that can be on the environment, that can be on nutrition, and lifestyle choices, so such as doing sports or being healthy or whatever. And when we understand social holistic health records, this is the interrelation among different health, holistic health records. So we consider also information from social media, but what we call about social is the federation of all these data sources. So we come from different sources, as I mentioned, hospitals, laboratories, people taking their vital data from their bodies, and so on. And from all this, we have medical records, we have data as such, we have data from laboratories, and so on. But the issue is that all those data, they are not connected between each other. So they are independent, they are heterogeneous. this limits our exploitation, and it limits the value that we can take from all this data. And the result is that we have ineffective and untargeted health policies. But what we want now in the future is to connect all those data, to add on the electronic health record more data, to connect them among themselves, to create relevant health policies. And this is what the CROWDHealth platform intends to do. So just to understand a little bit the whole context, we are offering services to citizens. They, of course, at the time of research, provide research data, probably without consent, but in any case, during the project, they are fully anonymized, as we will see later. And they get back, of course, policy adapted, health policies adapted to their situation, to maybe their geography, to current illnesses or diseases that are coming over. Oops, sorry, didn't want it to move. Then we have, of course, the health professional who can benefit from more interrelated data from different departments, not only their own data, but the connection maybe from other hospitals, maybe, I don't know, in Spain, every hospital has different healthcare system, EHR, and they don't talk to each other. The healthcare providers, of course, also benefit from this. They could use data from another institutions that they can help them understand different policies they can apply to their own institutions. And last but not least, the policymakers with combining different sources of data and amounts of data, of course, hopefully can produce better, more accurate policies. Oh, I'm going back, sorry. So that's all the elements contained in the CROWDHealth, but as I've been talking with Anna, I think it would be good that I don't only show you pictures, but I have a nice video to show you. Now we are at this point where we have already developed some prototypes for the cleaning of data, for the anonymization of data, for the storage of data, and the path from gathering data from different sources and putting them in one single holistic health record. And I think this video I'm going to show you will interest particularly Professor Clem. He mentioned this morning the fire, and this is completely showing how we use fire to connect all this data. So this is, no, sorry. Here I have this. So it's a short video, it's only 4 minutes. I will try to illustrate it with my own words. There is no sound, but you will understand somehow how it works, this holistic health record. So as I said, it's a health records that adds on different other elements that are coming from different sources of information, nutrition, lifestyles, activity, and so on. So this is a more technical picture. I will not talk about it, but what I understand is that we have events, what they call events. It's every time that we take information from a patient or from a citizen. And this information is a certain, is then converted into measurements, and all those measurements have to come together in a single language, I would say, which is converting all this into an HHR model. And soon we will see how the fire comes into play. A bit more. So measure can be a value, a quantity, and other kinds of measures. And here comes how we combine the model with the fire profile. So here we have the different mapping of coding For those who are more knowledgeable about the coding, it may be more interesting. I think it's almost self-explanatory. At least this is how it works behind the scenes. So the weight becomes an observation in the fire structure. Here I will talk later a bit more about all the partners that are providing data and which kind of data they are providing. Here we have an illustration of how data is cleaned. As we said, we have to see sometimes data are missing. We have to eliminate the whole EHR if not enough data is available. And this is the application that does the conversion. And it's already working. That's the whole story. And that's a picture of the gateway, where we can see how this data is called. Actually, like here we are calling a database from a partner. I will also mention that for us the most difficult part is to get the data. The partners announced that they had data, but we have a lot of barriers in order to really get the data sets. I see that it's not only our problem, and after 1 year we are starting with some data sets. So here is the conversion. I think that at this point we are almost over this demonstration. And I will go back to my presentation, where it is. Yes. So, yes, I wanted to mention the 6 pilot cases that we have. Actually, now we have even one more, because we have the Taipei Medical University. So we have the health centers. Those are the Karolinska Hospital in Sweden and Ulafe Hospital in the south of Spain in Valencia. And they both finally provide data from patients. Of course, Ulafe, for example, their data cannot go out of their institution. So what they provide is completely already anonymized data. And this is stored in a central server for others to be able to access and treat the data, make analytics, and so on. BioAssist is a company in Greece, and they collect data from vital sensors on the body, respiratory, blood pressure, weight, and other vital signals. CareCross is a company in the UK, and they collect social media data. So they have a portal about cancer, and what they do is they provide recommendations somehow in exchange with experiences from people saying that this medication, this nutrition, this kind of information that is also related to health care and how people manage their health with medication or sport, lifestyle, whatever. The FKI in Germany, they collect from, they have a living lab, and they collect especially from, they have like small kitchens, and people go there to cook, and we can observe how they manage. And they are also try to get more information about nutrition data, which is also a complete set of how to gather this data is complicated, because food is not classified in the same way in the different countries or different people. And then University of Ljubljana is providing a data set on children at school. Every year they make a whole census of their physical mass and physical activity. So So they are for many years doing this, and they have quite an important data set. So all these data set is what we combine. I don't know if I have still 2 minutes for a short demo of the toolkit. So I'm here. And this is to demonstrate how, because in the end, what we offer to policymakers, maybe it's here, okay. Let me go, because the technical part maybe is not so interesting here, but I don't see how to progress. Here, yes. So the idea is that policymakers then have a kind of interface, and they can choose from their different already existing policies. Each policy has KPIs, so indicators to know if it has, what are the components of these policies based, for example, here we can see that there is a policy on obesity, and they want to see if it's a question of children or age, and so they can put all the parameters and import from the various data sets that are available in the whole platform, select ranges of dates to analyze, and at the end see how policies have been somehow successful, or what is the impact of those policies based on the amount of data that CROWDHealth has been presenting. So I think this was more or less the last of my slides. Just to summarize, as we said, and I think it's not only the case of CROWDHealth, data is important, and they are so distributed and difficult to use all together, although it would be somehow very relevant to combine different sources of data. So hopefully with the CROWDHealth platform, we will be able, at least technically, to combine several kinds of data. I would say, as a project coordinator now, the issue I see with this project, or the challenge that we have, is that it's very technical oriented, and we still lack the inputs of medical doctors and policymakers to make it really coming to a successful end. So I hope that it will be, we will encounter, probably have people be interested and try our results, and to see if it can really work in real life. Thank you.
I think this is touch a very strong point. We all have a problem with data, and you're saying that perhaps the national bodies, certainly in age as digital, need to think about a harder format than the UK. Questions on the floor?
I noticed that with your last slide you said emphasis is on public health. I was wondering if you envisage this to be something that is accessible for patients and physicians as well. I wonder who would be your primary target?
The primary target would be effectively public health, and the design of the project was on this target. But of course, physicians will have access to this information, and I think it's really the secondary target. For the patients, it's a bit more complicated at this stage, especially for the privacy, because now, basically, as soon as the data is on use, and even for research, it's anonymized. So it's very difficult then to come back to each patient. But of course, the patients will benefit if a policy is applied to their case, but it's not, at this point, we are a bit limited in terms of going back to a personalized, let's say, recommendation due to the aggregation of data that then is difficult to disaggregate.
I've got a couple more. So, are you using Fire, you said, in this?
Yes.
Is it data in a Fire server?
Well, that's a good question. I don't think so, because I have not heard that we are using Fire server. I mean, this data is, we use Fire, and all the partners have signed a kind of agreement with FHIR, whatever, but in my understanding, the data is not stored or connected to a FHIR server. I don't know if now our servers can be called FHIR, but...
You might be able to call them, because most of the fires, the things serving a fire internally are what they were. And it's a communication thing that's FHIR. But what you mentioned, it was up and running. And people, I haven't made a FHIR product myself. They say it's very easy to build them. And usually they use a server to test them. There's 3 FHIR servers that you can test with. The other thing, I think, another connection there, you mentioned Indiana University. Did I hear the university that had the school information, was it from the States?
No, not from the States. Taipei Medical University, or we have several other universities, Piraeus, Slovenia, but not in the States.
More questions from the floor?
Well, just one more comment. This is designed to hide the data for it to become public self, but it seems like it wouldn't be hard to let it also keep the data at another model. You know, it's the same basic work of moving it around. But it raises the issue that we were talking about is the privacy makes it harder to do a lot of things that you could do quickly and easily otherwise.
Yes.
That's right. The national database, I'd say that the UK collects over 52 million patient data records, but you will get your hands on it very easily. You sign your name and blood, and they won't let you have the data keep. So.
Well, we could fix more things in health if we knew more information.
Okay. Thank you.
Okay, thank you very much for your attention.